thanks very much to the organisers for inviting us to talk a bit about our work that we've been doing in the national SD around medicines. So I'm going to talk through a few examples of when you begin to link medicines data to routine care data, what insights you can get. I always forget to say thank you, so I'm going to do that first. So thank you to all of the people on this slide and lots more. A lot of the work that I'm going to present today has been mainly done by Caroline Dale and Rohan Thakkar. So the medicines data infrastructure in this country is slightly broken. So we spend £20 billion on medicines just in England. That's not the UK, it's just in England. But we don't know if they're actually doing what they say on the tin because they're not routinely linked to health outcome data. So we can't actually test if drugs are cost or clinically effective. There is no ledger, so we don't know if medicines are used appropriately or inappropriately. And just to go back to the cost, this cost is second only to the workforce in England. So if these data were linked, we could actually do a great deal of work in terms of determining cost and clinical effectiveness, as well as addressing things like polypharmacy and deprescribing. So the COVID-19 pandemic changed some of this, but not all of it. And what it enabled is the development of TREs or secure data environments. This is one example, and the other example is Open Safely. So facilitated by the BHF Data Science Centre, which is led by HDR UK, the NHS set up a national TRE, which included HES data, some primary care data on dispensing, and there are many other data sets that are included. The other resource, of course, is Open Safely, which includes all of GP data, which is then linked to HES data and some other data, including primary care medicines. So the types of data that we have in these environments is primary care dispensing, which is serviced by the NHS BSA Authority, and also some secondary care electronic inpatient hospital prescribing. But we don't have any secondary care, what we call high-cost drugs, so the cancer drugs, drugs used as immunotherapies for rheumatoid conditions and so forth. So we don't have any of those drugs, so actually that is still missing. But when you begin to link at least these types of data with routine healthcare data, I'm just going to go through a couple of case studies of what insights you can begin to get. So the first is about how we can build resilience within the system. So this is the first case study. So we published this earlier on this year, and the paper is cited there. So what we wanted to understand is what the indirect effects of the COVID-19 pandemic were on cardiovascular risk factors. And one way you can do it is by looking at the primary care record and just looking at the diagnosis of primary care diagnoses. But the other way you could look at it is through medicines. So during the pandemic, QOF was no longer happening. There were no vascular health checks. There were no serendipitous measures of when you go to the GP, they'll measure your blood pressure, check your pulse, see if you've got AF. So actually, how then do you begin to measure the management of cardiovascular risk factors? So one way, as I mentioned, is that these clinical pathways are often actioned through medicines. So can we actually use the medicines to track the clinical pathway and then begin to understand actually what's happened to the clinical pathway? So what we did is we looked at the drugs that were used to treat the major cardiovascular risk factors using the BNF. We took the cardiovascular and the diabetes chapter, and we adjudicated the drugs to the major cardiovascular risk factors of hypertension, hypercholesterolemia, type 1 and type 2 diabetes. Of course, there's going to be some overlap because a lot of antihypertensives are also used for heart failure. But actually what we wanted to see is, can we get a general gist of exactly what's happening? Because if they're dropping in one, they're probably also, individuals are probably also being undertreated for all the conditions that these drugs might be used for. So this is work done in the NHS SDE. So we took medication records between April 2018 and July 2021, looking at the dispensed data in the TRE. And then we looked at the subgroups of CVD medications. And we then looked at incident medications as well as prevalent medications. And we stratified it by age, gender, ethnic group, and so forth, excluding individuals who didn't have valid IDs. So the results are shown here. So on the right-hand side, we've got the prevalent use. And so the top line is antihypertensive. So they're the most commonly prescribed drugs in primary care. The blue line is lipid-lowering drugs. The purple line is drugs used for type 2 diabetes. And the lowest green line is insulin, so type 1 diabetes. And looking at the other plot, this was looking at percentage year-on-year change. The vertical lines are actually the lockdowns. On the left-hand plot, you can see that there is an uptick before lockdown 1, particularly in insulin, which is actually quite interesting because if you remember, we were also Brexiting at the time. And these types of patterns you often see before holidays where there's an uptick in drugs that are sought after by patients because they know there's going to be a shutdown, so they might not be able to get their drugs. There was already some stuff in the press at the time that there might be insulin shortages. So we think that uptick is actually a combination of both the lockdown due to COVID, but also the worry that they might not get any insulin because of Brexit. But then what's really interesting is when you begin to look at incident data. So this is data from England, Scotland, and Wales. And at the first lockdown, you can see a sharp decrease in all of the cardiovascular risk factors and the drugs that were being used to manage them. And using hypertension as an example, we estimated that it was just approximately 500,000 individuals, 500,000 individuals that probably missed their first prescription of hypertension. And then using hypertension as an example and using the Royal College and NICE calculator, we were then able to begin to understand actually what impact that might have on future cardiovascular disease, just using hypertension as an example. So actually it's probably an underestimate. That really demonstrates in terms of that case study that linked medicines to health records actually can be used to monitor the health of the clinical pathway, particularly if they're actioned through medicines. And it actually shows how prevalent but also new users can indicate changes. And obviously this is cardiovascular disease, but you could do this in other drugs as well. So the next example is around medicine safety. So sodium valproate is a drug that's used to treat epilepsy, but it's also a drug that's teratogenic. So if a woman of childbearing potential or a woman who is pregnant takes it, there can be malformations in the child. And this has been a really ongoing problem with this drug, but also other drugs. During the pandemic, there was the Cumberledge report was published in July 2020, which looked at a couple of examples, including sodium valproate, trying to assess where in the system we can improve safety. The government's response was published in 2021. And what we wanted to see is using very much the type of analysis we had done for the cardiovascular disease work is actually, can we begin to use these linked data to understand if these, the Cumberledge report and the government's response, which would during COVID, if they actually had an impact in changing policy. So we used the population-wide data from England and Wales, so around 60 million individuals, and we looked at valproate in women and identified those who may be of childbearing potential in that age group. And then we looked at the impact of the regulatory changes, so the Cumberledge report and the government's response, and also looked at how COVID-19 actually impacted on the implementation of this advice. So very much in terms of the data flow, which is shown here, which I won't go to in detail, but we looked at through a medicines lens again, looking at the medicines in the first instance, and then identifying individuals who were of childbearing potential, but also pregnant women. So this demonstrates what we begin to find. So this is sodium valproate dispensed in January 2019 to 2021, comparing men to women. So men is the top line and women is the bottom line. And as you can see, the COVID probably didn't impact it because actually the slope of that line probably didn't change. The lockdowns, again, are indicated by the vertical lines. And then we were able to also calculate rates of dispensing of sodium valproate across different regions of England as well, which can then actually benefit in terms of implementation at a regional basis. So regions can identify which women in their patch are on these drugs and actually can they then stop them. We were also able to look at other anti-seizure medications, and a couple of examples are shown here, both across the study period. So we were able to look at carbamazepine, topiramate. So the blue lines are men and the yellow lines are women. And you can see in sodium valproate, there's a big chunk that's taken out of women of childbearing age. So actually it looks like we are doing quite well, and COVID-19 didn't really impact this policy change. So topiramate is an interesting example, which is seen at the bottom, because there's been a recent publication that has raised the question of whether topiramate, actually like valproate, is teratogenic. So more work to be done there. We were then also able to use the primary care record to begin to infer which diagnosis these women were being treated for. So sodium valproate is licensed for epilepsy, but also bipolar. And so that is the majority of individuals you should see with those diagnoses. But we did find that there were women who were on valproate for other reasons, and that could be a really low-hanging fruit in order to target stopping or deprescribing these drugs. We were then also able to look at women who were dispensed anti-seizure medicines during a pregnancy episode. So we were able to identify pregnancy from both the primary care record as well as the linked secondary care record, and then look through the dispensing record and see actually which women got that drug during pregnancy. And I think this is the first time we've been able to do this and look at those rates across that study period. So in summary, what we were able to show here is that the rates of use of sodium valproate in women during pregnancy fell, but continued to do so during the COVID-19 pandemic. But what we'd like to think about in the future is using linked healthcare records to investigate how policy changes impact on seizure control and mortality, because obviously sodium valproate is also the leading evidence-based drug for generalized epilepsy disorder. So if you're going to stop it, actually what happens to the mortality and morbidity of these patients? But this approach could also then be used to interrogate other teratogenic drugs and look at outcomes in children as well. So just in summary, at the end, what next, and then what are the opportunities in using medicines data that are linked? So I think what we need to aim for is identifying all medicines used in healthcare and then being able to link them to primary and secondary care, really building a comprehensive medicines data foundation. And then working in partnership across agencies to use the data for clinical and cost effectiveness analysis to see actually are these drugs really doing what they say on the tin, but also pharmacovigilance and further research and translational programs. And I'll stop there. Thank you.